Okay, hi again, everyone. So, neuro lecture taken by Denali. Everyone enjoy. Take it away.
Hi everyone. My name's Denali. I'm one of the third years and I was at MMC this year. So I'll be talking through neuro and I'm very well aware that this is a pretty heavy topic. Okay. Is that better?
No, it's still the speaker view. I'm not sure what's going on.
I'm also not sure what's going on. Let me try that.
It'll be okay. Anyone else?
Speak of you?
Oh no, that's good.
Okay.
Cool.
So it's a pretty heavy topic, but I'll go into most high yield things. So if you have any questions, chuck it in the chat, and I'll go through them later on. Okay. So the way I've divided this lecture is that first of all, we go through some of the more theory stuff. So we'll go through the neuroanatomy, especially of the cerebral hemispheres and all of the special areas of that, like Broca's area, Wernicke's area, that sort of stuff. We'll talk about the brainstem, the cerebellum, all of the neurological pathways, so the spinal tracts, the optic pathway, and the indirect and direct pathways. The circle of Willis for the blood supply, and then all the parts of the meninges and the skull, that sort of stuff. And then for the second part of the lecture, we'll go through some of the more pathology. So we'll talk about strokes and hemorrhages, a bit about seizures, a bit about Huntington's and Parkinson's, because they're related to the indirect and direct pathways, as well as the three infections, so meningitis, encephalitis, and brain abscesses. So we're studying the cerebrum. So the way I suggest to do it is to study each lobe separately, and within each lobe, make note of how many gyri and sulci there are, and then along with each lobe, figuring out the blood supply and the main function of each lobe. So frontal, parietal, temporal, and occipital separated into the four lobes, as well as that have an all right understanding of what the brain looks like from the medial view, so if it's been cut down the middle. So starting with the frontal lobe. The frontal lobe has 3 gyri and then the precentral gyri, so 4 altogether. So inferior, middle, and superior gyri going from lateral to medial. And then as well as that, we've got 2 sulci separating that, so the inferior sulcus and the superior sulcus. And then separating the precentral gyrus, you've got the precentral sulcus and then the central sulcus. So the frontal lobe is where all of the high order functioning of a human happens. So it controls all of your personality and your behavior and that sort of stuff. And the 2 most important areas of the frontal lobe are the Broca's area and the primary cortex, which we'll talk about in a little bit more detail. It's supplied by both of the anterior and the middle cerebral arteries. So the anterior artery does more of this medial section, whereas the middle cerebral artery does more of the lateral section. So speaking of the Broca's area, so the Broca's area is found in the frontal lobe, on the left side in most people, because for most people that's their dominant side. So if you have a pathology in the dominant sphere affecting the Broca's area, you end up with Broca's aphasia. If you have a pathology in a similar area, but in the non-dominant hemisphere, you might end up with some speech difficulties, but it's not going to be entirely Broca's aphasia, because that's not where Broca's area is. So what Broca's aphasia is described as non-fluent and grammatically incorrect speech. And the way that I interpret it is that the person understands what other people are saying. They understand what's going around you, but they can't respond in a way that's in any way meaningful, right? So it's like them saying, I can understand what you're saying, but I can't respond in a way that makes sense to you. And I can understand that this deficit exists and it distresses me. So that's what Broca's aphasia is. And we'll talk about Wernicke's aphasia in a second and how it's different from that. The other part of the frontal lobe that's important is the primary motor cortex, which is the exact same thing as the precentral gyrus, so this red part here. What the primary motor cortex does is that it controls skeletal movement, so voluntary movement of the contralateral side, the opposite side. Of the primary motor cortex, if you have body parts that require more finer control, for example, the fingers, they will have a larger area on that gyrus that's mapped for them. So things that don't require as much fine movement will have a smaller area defined for them. From medially to laterally, it's arranged roughly from feet to head. So as you can imagine, if you have something going wrong up here in the medial area, it's more likely to affect your legs than it is to affect your arms and your head. So that's the primary motor cortex. The other sort of less, I guess, lower yield things that sometimes come up are the premotor cortex and the supplementary cortex. The supplementary cortex isn't in this diagram, but the premotor cortex is this orange part, and the supplementary cortex is the bit before that. The premotor cortex essentially informs the primary motor cortex of what's going on. And the supplementary cortex is like the part before that. So an all right way to remember that is that the supplementary cortex is where you think about doing some sort of motion, some sort of action. You're thinking about moving your hand. The premotor cortex is planning the movement. It's saying like, okay, if I need to move my hand, I need to move different muscles to make sure my hand's in balance. And the primary motor cortex is the one that actually carries out the action. Both of them, like I said, are lower yield. They have come up in exams, so it's good to know where they are and roughly what they do, but I wouldn't go into more detail in the study for that. And that's everything from frontal lobe. All right, next up we have the parietal lobe. So similar to the frontal lobe. So it has it's actually not that similar to the frontal lobe, never mind. It has lobules instead of gyri because they're more lumped together. So there's an inferior parietal lobule and a superior parietal lobule, as well as the postcentral gyrus. The postcentral gyrus is the same thing as the primary sensory cortex. So the parietal lobe, because it has this primary sensory cortex, one of its primary function is to do the sense of touch. And in particular, it's the sense of touch that's non-special. So anything that doesn't need its own specialized organ. So it's not going to control vision, it's not going to control hearing or taste. It's just going to control things like pain, touch, heat, that sort of stuff, right? Similar to the frontal lobe, it is also controlled, supplied by the anterior and anterior and middle cerebral arteries. And the same way that in the frontal lobe, the medial part of the parietal lobe is the anterior artery, and the lateral part is the middle cerebral artery. So in the parietal lobe, you've got the primary sensory cortex, which is this blue guy over here. This is the exact same thing as the postcentral gyrus because it's after the central sulcus. And like I said earlier, it's responsible for collecting the non-special sensation of the opposite side, the contralateral side. And in the exact same way that for the primary motor cortex, if you have areas of your body that require finer, more accurate sensation, again, with your fingers, they'll have a greater area on them, so a larger area. It is also arranged medially, laterally, feet to head. So if you have something messing up here, that's medial, so you'll lose sensation in your leg as opposed to your. That's it for parietal lobe. Temporal lobe is next. So the temporal lobe is has an inferior, middle, and superior gyri, and it's associated with visual memory as well as your hearing. And the way that I remember that is temporal means time. So temporal lobe refers to your memory. Also, it's like near the ears, so it controls a lot of hearing and comprehension. And this one is supplied by the middle and the posterior cerebral arteries. So the middle does sort of this area, and the posterior does the inferior part. The most important thing about the temporal lobe is Wernicke's area, and technically it lies partially in the temporal lobe area and partially in the parietal lobe. It's not as well defined as Broca's area. Wernicke's area is also present in the dominant hemisphere, which again is on the left side of most people. So if you have a pathology in the dominant hemisphere in Wernicke's area, you'll end up with Wernicke's aphasia. And Wernicke's aphasia is the one that's known as word salad. So it's the one that's known as word salad. And so people will talk in fluent sentences. They're not going to stutter. They're going to say words clearly, but none of the words make sense. And also their comprehension is also impaired. And so they don't understand what they're saying, and they also don't understand what you're saying. So I can't understand what you're saying, and I can't respond correctly in a way that makes sense to you, and I'm not aware of this deficit. So people aren't going to be distressed if they have Wernicke's aphasia. Just if both understanding and speech is damaged, the occipital lobe is damaged. The occipital lobe can be damaged. Depending on which artery, if it was an artery that's causing the lesion, the occipital lobe can also be damaged, you're right. But Wernicke's, you have to understand that it's not just blood supply is that can cause a lesion. You might also have a tumor there that's pressing on that area, or an infection, a brain abscess affecting the area. So you could just get Wernicke's aphasia that doesn't affect your vision. So is there a way to determine which side is someone's dominant hemisphere? Not with clinical examination. So you can do it with brain scans, I think MRI scans, where you get like people to do stuff and say stuff, and you just watch which side lights up. I think that's the only way to determine which side is the dominant side. Otherwise, you just assume it's left, because there's no way of doing it with clinical examination. Good question. All right, occipital lobe. So the occipital lobe, the only thing that the occipital lobe does is visual perception. And in the occipital lobe, you've got a superior, middle, and inferior. You've got 3 gyri. And this one's only supplied by the posterior cerebral arteries. And the only thing that it does is visual perception. All right, so looking from a medial view, the things that you can see here, so you've got the frontal lobe in yellow, parietal lobe in orange, and then the occipital lobe, temporal lobe down here. When you're looking from a medial view, you start to see the cingulate gyrus. And the only thing you need to know about the cingulate gyrus is that it's important for emotion processing. I think the way I used to remember it is that you keep your emotions inside. So the cingulate gyrus is inside the brain. The other thing that you can see here is in purple, you can see the corpus callosum. The corpus callosum is white matter, and everything that's white matter is just tracts of axons. And in particular, the corpus callosum is responsible for connecting the 2 hemispheres together. There's 4 parts of the corpus callosum. So the rostrum, meaning beak, so it's this pointy bit down here. The genu, the bend genu means knee, so it's the bend. And then you have the trunk, and then the splenium at the end. The only clinical correlation for the corpus callosum is that you can do a corpus callosotomy. If someone has really, really severe epilepsy, the way that seizures sometimes work is that they start in one area of the brain and spread through to the entire brain. So if you sever the corpus callosum, then you prevent the, the seizures from spreading throughout the whole brain. Where would the ventricles and the basal ganglia be? You can see the lateral ventricle sort of here, and then the basal ganglia should be in this middle part over here. We'll talk about the ventricles and basal ganglia later on as well. This diagram isn't fantastic for showing the rest of the ventricles, but they would be superimposed on the diagram here. Oh, that's all of the very, very quick overview of the neuroanatomy. Next up is your brainstem. So we'll go through the brainstem, and there's a lot happening here, so I'll try to slow down a little, and we'll go through a little bit about the cranial nerves as well. So in the brainstem, we have the diencephalon, which sits up here, the midbrain, the pons, and the medulla oblongata, and we'll go through each one of them one by one. So diencephalon first. So in the diencephalon, which is the purple part up here, and from the other diagrams, you can see that it actually extends a little bit more superiorly. The diencephalon is essentially the four thalami, if you will, the four thalamuses. So most importantly, you've got the hypothalamus, and in this diagram, it's sort of all of these like colored marble things and stretching down into the posterior pituitary as well. So what the hypothalamus does is that it is the control center, for all of your endocrine function. It has dopaminergic neurons, so they produce dopamine, and that dopamine has some part in inhibiting prolactin, and it can also stimulate lactation. So again, it's part of the endocrine system. The other two things it has are the supraoptic and the paraventricular nuclei. And if you remember from endo, those two nuclei, so the supraoptic one produces ADH and paraventricular produces oxytocin. And so they produce their hormones up here, and the hormones get stored in the posterior pituitary down here. Then they also have a bunch of other nuclei that create other things which are that important or more relevant. But that's what the hypothalamus does. The thalamus, on the other hand, I don't know how clearly you can see this. It's this bean-shaped thing over here. So you have two of everything, but especially of the thalamuses, you have two thalami. And they're joined together, connected by this interthalamic adhesion, which is this dot that you see in this picture. You can see it up here as well. So they're connected by a little adhesion. What the thalamus is actually responsible for is that the thalamus is the main conductor of all of the sensory information coming from your body. So all of your spinal tracts, which we'll talk about later, the spinal tracts all go through the thalamus before it gets rearranged to where it needs to go in the brain. That's all you need to know about the thalamus. After the thalamus, you've got the epithalamus. The epithalamus is this bit at the back here. The most important part about the epithalamus is this little bean thing over here, which is the pineal body. The pineal body produces melatonin, and it produces melatonin in response to darkness. And because of that, it's responsible for regulating the circadian rhythm of the human, making sure that we go to bed at the right time and wake up at the same time. The other part about the diencephalon is the subthalamus, which is sort of this area here. You don't need to know too much about the subthalamus, but when we talk about the indirect and direct pathways later on, one of the pathways goes through the subthalamus, and that's all I know about it. That's all you need to know about it. Any questions about the diencephalon before we move on to the other parts of the brainstem? I am going to take that as no. So going back to our big diagram, we've done the diencephalon. Midbrain I'll leave for a bit, but I'll talk about the pons and the medulla before I talk about the midbrain. So the pons is this big lumpy thing in the middle. And what the pons has is you can see a lot of cranial nerves coming out of the pons. It contains a lot of the nuclei, so the cell body of most of the cranial nerves. And as you can also see, it has all of these peduncles, which is how the pons is actually connected to the cerebellum, which sort of, if you use your imagination, sits sort of like this at the back. In terms of the medulla oblongata, it contains a lot of the autonomic centers that regulate all of the basic autonomic functions, so things like circulation and breathing and gastrointestinal activity. All of the centers are in the medulla oblongata. The other things that are present there are all the centers, like the center for sneezing, center for vomiting, swallowing, coughing, all those like things that you do without thinking are in the medulla. The spinal pathway tracts also go through here. If you can notice in the in this view, you've got two lumpy parts in the middle and then two lumpy parts at the side. So the bits that are in the middle are the pyramids, and the bits that are at the sides are the olives. And the way that I remember is that the olives are lateral because they both have L's in them. So the spinal tracts that are pyramidal will go through the pyramids, and the spinal tracts that are extrapyramidal would go through the olives because they don't go through the pyramids. And all of the information that I said is also in text on this slide as well. So the midbrain was the only one that we didn't go through because the midbrain is something that's tested in anatomy more so than you really need to know the functionality of it. For functional purposes, the midbrain has the substantia nigra, and the substantia nigra has two parts. It has a part called the pars compacta, and that produces dopamine, and the pars reticulata, which produces GABA. And so in both of these views, this little line here is what the substantia nigra is. So you can see it there and you can see it here as well. On like a anatomy specimen that you might get given an image of, the substantia nigra will always look black because it's substantia nigra meaning black substance. For anatomy purposes, knowing these two diagrams are really good. So if we break it down a little bit. So up here you can see the midbrain, right? And we have these, the blue parts here, the superior colliculi and the inferior colliculi. This superior cross-section is taken as a cross-section going through the superior colliculi, right? You can see the superior colliculi over here. The inferior section is going through the inferior colliculi, right? So that's what these two cross-sections mean. Looking at these two cross-sections, some of the more common features you can see is that the cerebral aqueduct is in the middle, which carries CSF, as well as the crus cerebri, which is like these tail parts. And you can see the cochlear nerve coming out of the inferior cross-section, but not the superior cross-section. So from a purely anatomical second-year exam point of view, it's good to be able to pick out these things, the tectum, tegmentum, crus cerebri, the peduncles, and the aqueduct and the substantia nigra, being able to pick them out from an image like this, whether you get given a diagram like this, or whether you get given like a picture of a specimen that looks like this. In terms of buzzwords, the kind of buzzwords, if you flip all of these images around, so that instead of having the posterior aspect at the top, you have it at the bottom. The superior view apparently kind of looks like Mickey Mouse. So if you see Mickey Mouse eyes, you know that you're in the superior section, and that the crus cerebri in both sections are the ears. Any questions with that? You don't need to know what a lot of these do. You just need to know that they're there in an anatomy, from an anatomy point of view. Cool. Okay. Cranial nerves. I'm not going to go through what cranial nerves do because that's not a great use of time. In terms of cranial nerves, there's only four that technically decussate, and by decussate I mean crossover. The optic nerve obviously does because it crosses over at the chiasm. The trochlear nerve kind of does because it arises posteriorly and like switches around. So the left one always controls the right. The facial nerve also decussates partially, and the hypoglossal nerve decussates as well. But we'll talk about these crossing over later on when we talk about spinal tracts. This diagram, what it's showing is where the where the cranial nerves come out of the brainstem. There's a rule of four, so there's four that come out above the pons, four that come out within the pons, and four that come out below the pons. All of the cranial nerves that are factors of 12 come out midline, and everything else comes out laterally. So if I show you this example, where you can, this is the kind of diagram that I'm referring to, which is another one that might come up in anatomy imaging questions. If you can draw out a little mini diagram that looks like this, you'll be able to identify which cranial nerve is which, even like without labels. And in this version of this drawing, I've just written out a little bit more detail about what each of the cranial nerves looks like. The other thing about the cranial nerves that I think is good to know is where they come out of the skull, so which fissures. So I made up a very silly mnemonic. Children of some red orangutan in Japan hate mothers. So you've got and that's in order. So cribriform, optic canal, superior orbital fissure, the foramen rotundum, foramen ovale, internal acoustic meatus, jugular foramen, and the hypoglossal canal. So it's good to know what goes out of each of those holes. The other one that gets mentioned a lot is the foramen spinosum. And the foramen spinosum is, I don't know how clear it is, but it's here. It's next to foramen ovale. The clinical importance of the foramen spinosum is that the middle meningeal artery comes through here and it runs along the side of the pterion. And the pterion is the thinnest part of the temple. So it's liable for injuries if you get hit in the temple, that the middle meningeal artery can cause some epidural bleeding. Yeah, we're up to cerebellum next. Does anyone have any questions about the brainstem before we move on? No? Okay. So with the cerebellum, we'll split it into structural anatomy and functional anatomy. So just looking at the structural anatomy, this is what it looks like. It sits in the posterior fossa of the skull. We need to know where all of the nuclei are, as in the nuclei of the cranial nerves.
Yeah.
No.
Cool.
Okay, so the cerebellum sits in the posterior fossa of the skull. There's three lobes. So you've got your anterior, posterior, and the flocculonodular lobe. And the way that it's connected to the midbrain and pons is that you've got these three peduncles here: superior, middle, and inferior cerebral peduncles. It's separated from the brainstem by this, the fourth ventricle. And because of the way that the fourth ventricle and the cerebellum sit, you can imagine that any swelling of the cerebellum results in this fourth ventricle being squashed and obstructed. And so you end up getting hydrocephalus, so buildup of CSF within the brain, which can cause a lot of damage. If you cut down the cerebellum, you'll see these tracts. which is best shown in this diagram. Oh, you can see it in here as well, the little branches that go out. So that's called arbor-vitae, and they're just white matter tracks. So all the cell bodies are all over here, and that's what's connected to the rest of the brain. So that's the structural anatomy. In terms of functional anatomy, this is a summary. On the next slide, it's in more detail, but you can read through that in your own time. So what the cerebellum actually does is that it's responsible for movement coordination. It's responsible for muscle tone, figuring out where you are in space, so your proprioception as well as your balance. So you can imagine that if your cerebellum gets damaged, you lose control of your balance and your coordination. So functional anatomy is a little bit different. Functional anatomy is separated into the lateral hemispheres, the vermis or the spinocerebellum, which mean the same thing, as well as your flocculonodular nerve, which is sometimes also called the vestibular cerebellum. So so the lateral hemisphere is where your cerebellum plans movements, right? So if you have some sort of damage to your lateral hemisphere, you end up with something called ipsilateral ataxia. And what that is a lack of coordination in your limbs. So this is where you end up with things like not being able to do dysdiakinesia properly, or the finger nose, or ballistic tracking, those kind of things. So you'll have ipsilateral ataxia, which means if your left side is affected, you'll get poor dysdiakinesia in your left side, on the same side. If your vermis is affected, so the vermis is responsible for maintaining movement. And if your vermis is affected, you get something called truncal ataxia. So you get loss of coordination, but in the body. So as you can imagine, that's like people can't sit up straight because they'll fall towards one side. And then the flocculonodular lobe controls your balance and your gait. And so if you get a damage there, you actually end up with nystagmus. So if you get an exam question that's like a patient has nystagmus and isn't doing dysdiakinesia or isn't doing ballistic tracking properly, you know that the pathology is in the cerebellum. And if they're very specific, you might be able to narrow down which area of the cerebellum is truly affected. So as promised, here's all of that in more detail, which I'll go through. All right, brain pathways. Have you guys done the spinal pathways and the direct and indirect pathways yet? Yep. Okay, cool. So there's a lot of pathways, but I'll try to explain them in a way that makes sense. So what the spinal tracts actually are is the way that the brain communicates with the body and how the body communicates with the brain. So they can go up and down, ascending or descending. So I've color-coded them to fit in with this diagram. So the descending ones, so the motor pathways, are going to be red, and the ascending ones are going to be blue. So in ascending, you have 4 types. You've got the dorsal columns, the lateral and then anterior spinothalamic tracts, and then the spinocerebellar tracts. Descending, you've got 2 types. You've got your conscious motor control, which goes through the pyramids, and that's your lateral and anterior corticospinal tracts and your corticobulbar tract. But you've also got subconscious tracts. These are extrapyramidal, so they go through the olives rather than going through the pyramids. And there's 4 of them. They're much lower yield. So I'll go through these pathways in this lecture, but I understand that it's a bit confusing. So I've also got some extra notes that you can read through in your own time. But all right, so let's start with the dorsal columns. DCLM, dorsal column medial lemniscus pathway. Dorsal starts with D, distal starts with D. So the DCLM collects your distal sensation. So if you think back to your neuro exam, all of the distal sensations are proprioception, vibration, and 2-point discrimination. Right? There's two bundles of this. So if you look on this diagram down here, you've got gracile fasciculus and the cuneate fasciculus. Fasciculus just means bundle. So the gracile fasciculus, the way that you have a gracilis muscle in your leg, the gracile fasciculus controls your, collects information, from your leg, whereas the cuneate fasciculus collects information from your arm. Both of these decussate crossover at the medulla. So as you can imagine, if you have some sort of lesion below the medulla, so below the medulla, a lesion at the spinal level or up until the medulla, it'll be ipsilateral. So if you damage it here, it'll be on the same side. But anything above the medulla, because this is after it's been crossed over, it'll be contralateral. Yeah. Then you've got your lateral spinothalamic and anterior spinothalamic. So in this diagram, the lateral spinothalamic is all of this, whereas the anterior spinothalamic is this little part. So that's how I remember the lateral technically does more than the anterior. So lateral does pain, temperature, and crude touch, whereas anterior does only crude touch. The lateral spinothalamic decussates immediately at the spinal cord. So the lateral one is the purple one on this diagram. As you can see, if you have a lesion at that spinal level, the loss of sensation would be ipsilateral. Whereas if you have a lesion anywhere above, the loss of sensation will be contralateral. The anterior spinothalamic is a little bit different. The anterior one stays ipsilateral for a couple of spinal levels before it crosses over. So if you have a lesion at the spinal level, the loss of sensation would be ipsilateral. If it's a couple of spinal levels higher, it would also be ipsilateral. But after it's decussated, it will be contralateral. And so those are the two spinothalamic rods. So then you have your spinocerebellar pathways. The spinocerebellar pathways connect your body to your cerebellum. And there's 3 tracks, and their job is to carry proprioceptive information to the cerebellum. So tell your cerebellum where your body is in space. There's 3 tracks. So you've got a cuneocerebellar, anterior, and then posterior spinocerebellar. So cuneocerebellar does C8 and up, so it does your arm. Anterior spinocerebellar does your trunk, and then posterior does your legs. They all have ipsilateral innervation. However, posterior and cuneocerebellar, so the number 1 and number 3, they're the only ones that are truly ipsilateral. So they're the ones that look like they're the purple ones, right? So they start on the same side, they stay on the same side. So a lesion anywhere is always going to be ipsilateral, loss of proprioception. The anterior does something stupid. The anterior decussates twice. So it decussates at the spinal level, but then it also decussates at the brainstem. So there's one else. So decussates here and decussates here. So because it double decussates, it's technically ipsilateral, but you can understand that if you have a lesion at the spinal level or at the lesion above the brainstem, the loss of proprioceptive information will be ipsilateral. But if you have a lesion anywhere in the middle, it'll be contralateral. Yeah, and that's all of the ascending pathways, all the blue ones. Going into the descending pathways, so these are all the motor pathways connecting your brain to your skeletal muscles, or your muscles in general. So you have your lateral corticospinal tracts and the anterior corticospinal tracts. And over here, you can see the lateral one is just a big lump of red. and then the anterior one is this little lump of red down here. So lateral starts with L, limb starts with L. So your lateral tract is your limbs. So it does the skeletal muscle control of your limbs. It decussates directly at the pyramid. So it's big. It's this big bundle that you see here. So if you have a lesion below the pyramids, your loss of muscle control will be ipsilateral. If it's above the pyramids, it'll be contralateral. The anterior spinal tract, however, anterior starts with A, axial starts with A. So it does your axial skeletal muscle control. It decussates, it crosses over at the spinal level. So if you have a lesion at the spinal level, it'll be ipsilateral. If the lesion is any higher than that, it'll be contralateral. The other important descending pathway is the corticobulbar tract. The corticobulbar tract is not shown in this diagram because it does not go into the spinal cord, because the corticobulbar tract controls the muscles of your face and neck. So it has no need to go into the spinal cord. So all it does is that the nerves start in the cortex, they go into the brainstem, and then they just go directly out into the muscles. In terms of decussation, only, like I said earlier, only four cranial nerves decussate, but the optic nerve isn't motor, so we're not going to talk about the optic nerve. So the facial nerve has contralateral innervation for the lower quadrant of the face, so completely crossed over, but it has mixed innervation for the upper quadrant. So this is where your Bell's palsy and your stroke comes in. So if you have an upper motor neuron lesion of your facial nerve, it's forehead sparing because you've got your other facial nerve that comes in and helps out with the forehead. But if you have a lower motor neuron lesion of the facial nerve, you have a lesion after the facial nerves have mixed. So the loss of motor function includes the forehead. The hypoglossal nerves are completely contralateral. So if you have an upper motor neuron lesion of the hypoglossal nerve, you have contralateral, opposite side muscle wasting. So the tongue points towards the muscle wasting. So the tongue technically points away from the lesion. But if you have a lower motor neuron lesion, you have ipsilateral muscle wasting. So your tongue points towards the lesion, if that makes sense. The trochlear nerve is contralateral, but that's not because it crosses over, it's just because it rises posteriorly. So if you have something going on with the right trochlear nerve, the left superior oblique is affected. And all of the other motor function of all of the other cranial nerves are mixed. Yeah. The other four descending pathways, the subconscious ones, the ones that go through the extrapyramidal tracts, they are not important. They're the ones that connect your cerebellum to your body. So all of the other three descending pathways that we talked about, connected the cerebrum to your body. So these ones connect the cerebellum to your body. So they're important for example, if you hear a noise, that you turn your head towards a noise. But like I said, they aren't that important, but I do have notes on them that you can read about afterwards. Very, very, very low yield. Before I move on to the optic pathways, does anyone have any questions about the spinal tracts? If not, we'll go on to the optic pathway. I'm sure you guys already have been taught about the optic pathway, so I won't labor too much on this point. But what I did want to point out is that at a second year level, you don't need to know too much more than bitemporal hemianopia, which is what you get if you have a pituitary adenoma, or just the entire loss of one side of your vision. So as this diagram is the best to show this. So if you have a pituitary adenoma that presses on your optic chiasm, for some reason it presses on those two middle divisions of the optic nerves first. So if you follow along with the middle divisions, that's this red part over here and this blue part over here, and they control the outer visual field. So that's why if you get a picture of your adenoma, you'll lose the outer parts of your vision and you end up with bitemporal hemianopia. Now, the patient might not actually notice that they have a visual defect, because just because you lose part of your visual field doesn't mean that you see black in the area. They just don't see in the area, if that makes sense. So in the stem of a question, it probably wouldn't be something like the patient noticed vision loss. It'll be like the patient keeps bumping into things on their left side, so they've lost the left side of their vision. That's all I'll talk about the optic. The indirect and direct pathways. So this is what involves the basal ganglia. So what the indirect and direct pathways are, they're a way of connecting the cortex to the thalamus and then back to the cortex. So it creates a loop. So what these two pathways are really, really important for is to control movements of your skeletal muscles. So it modulates their movements. These two pathways are controlled by dopamine, which we'll talk about in the next slide. So if we follow along the direct pathway, which is purple, the two neurotransmitters that are important for these two pathways are glutamate, which just stimulates whatever's next in the pathway, or GABA, which inhibits the next thing in the pathway. The thing about GABA is that if you have no GABA, it doesn't inhibit, so it technically stimulates whatever's next in the pathway. So if you follow along with the direct pathway, you've got your cortex. The cortex always secretes glutamate. The glutamate stimulates the striatum, and the striatum produces GABA. So the striatum produces more GABA, and more GABA inhibits the globus pallidus internus. And having no GABA means that there's disinhibition of the thalamus. Disinhibition means that it's technically stimulated. So the thalamus is stimulated, and so there's going to be increased movement via the cortex. So the net purpose of the direct pathway is to increase movement. Instead, if we follow the indirect pathway, same thing, the cortex produces glutamate, which stimulates the striatum, and the striatum, as usual, produces more GABA, and that more GABA inhibits the globus pallidus externus. The globus pallidus externus produces GABA, but it's been inhibited, so it's not going to produce GABA, which is going to cause inhibition of the subthalamic nucleus. So the subthalamic nucleus is disinhibited, so it's going to produce more stuff. So it's going to produce more glutamate, and that's actually going to stimulate the globus pallidus internus. Then the globus pallidus internus is stimulated, it's going to produce more GABA, so it's going to inhibit the thalamus, and because the thalamus is inhibited, it's going to produce decreased movement. And so that's how you get decreased movement with the indirect pathway, but increased movements with the direct pathway. Like I said earlier, these can be modulated by dopamine. Dopamine affects the indirect and direct pathways in different ways, and this dopamine is produced by the substantia nigra in the brain. So the parts that I've highlighted in yellow, right, are the parts that are different from the normal function. So as you can see, nothing is, yes, striatum is supported, yeah. So the parts that I've highlighted in yellow are the only things that change when you add dopamine. So as you can see, none of the purple parts are highlighted. So what that tells you is that when you add dopamine to the direct pathway, it just makes the direct pathway work more. So the direct pathway already increases movements. If you add dopamine, it's just going to increase movement more. So for the direct pathway, it binds to D1 receptors. However, for the indirect pathway, it binds to D2 receptors. And as a result of that, it actually inhibits the striatum instead of stimulating it. And because the striatum is inhibited, it sort of overtakes what the cortex is trying to do. And so all of these yellow highlighted parts are now opposite. So instead of there being more GABA, there's less GABA, etc. And because we've switched what the indirect pathway does, it now increases movement by the cortex rather than decreases movement. So in general, if you add dopamine to your indirect and direct pathway, you'll end up with more movement. Does that all make sense? Or does anyone have any questions about that? What's the difference between D1 and D2 receptors? D1 only acts on the direct pathway, and when dopamine binds to D1, it stimulates the direct pathway, whereas D2 only acts on the indirect pathway. And so when dopamine binds to that, it does a different function, so it inhibits the striatum. You shouldn't have to know. In terms of the location of this nuclei, you shouldn't have to know it in great detail. Have you guys been taught that diagram by Ali that has like a K and then it has all of the basal ganglia? Maybe.
I think so. No.
Okay. How about I'll put up a diagram of the location of the basal ganglia stuff. When is it modulated? When do we have it modulated versus when it's normal? Excellent question. I would assume just as the body needs. What I can tell you is what happens when it goes wrong. So when the body either produces too much dopamine or doesn't produce enough dopamine, which stuffs up the pathway. You have to understand that what this pathway is responsible for doing is that the cortex is like, I want to make a movement. And then the basal ganglia is like, okay, let's just double check and make sure that this movement is something that you actually want. So we'll double check that and then we'll get back to the cortex and be like, okay, we approve your movement, go ahead with the movement. So if you have something going wrong, right? The cortex is like, I want to make a movement, and the basal ganglia is just like, no, we're not going to let you make the movement. And so that even though the person themselves want to make a movement, the brain's not letting them make a movement. Does that make sense? However, in terms of like how and why dopamine modulates the pathway, it would just be as it's needed by the cortex, if that makes sense. Did I miss any questions? I don't think so. Okay. All right. So we're up to the blood supply. So just the circle of Willis. So what the circle of Willis is it's an anatomic formation. So it's a circle. And it's the reason that it's a circle that it's designed to prevent ischemia. So there's redundancy in terms of blood supply. So ideally, in a perfect world, if you have a little bit of like a reduced blood flow in, for example, in a vertebral artery, that the rest of the arteries will be able to make up for it. In terms of studying the circle of Willis, it will be important to know where specific branches come out of, and in particular, all of the cerebral arteries, and also the ophthalmic artery, because it comes off the middle cerebral artery. The only clinical point, other than strokes, which we'll talk about later, the only clinical point is giant cell arteritis or temporal arteritis, which is the same thing. So what giant cell arteritis is, it's an autoimmune disease that causes inflammation of small and medium arteries, right? So this can happen anywhere in the body. In particular, it can affect the temporal artery, which runs outside your skull, which is how it usually presents. So people come in with like headaches and they're like, I can't, it hurts when I chew, or I have a ripping headache on one side. But at the same time, it can affect the ophthalmic artery, even though the ophthalmic artery and the temporal artery aren't closely connected. And because it can affect the ophthalmic artery, there's a massive risk of blindness, which is why you want to be able to recognize GCA, recognize temporal arteritis, and treat it. In terms of blood supply of the cerebral arteries, you've probably seen diagrams that look like this. And we talked about this a little bit earlier. So the middle cerebral artery does essentially most of the brain, right? So it does this lateral middle chunk over here, whereas the anterior cerebral artery does the medial aspect, the inside of the hemispheres. As you can see from it's the motor homunculus up at the top and the sensory homunculus at the bottom, the medial aspect is all like lower limb. So if your ACA is affected, you're more likely to have lower limb, either sensory loss or motor loss. Whereas if your middle cerebral artery is affected, you're likely to have upper limb sensory or motor loss. And the posterior cerebral artery controls the occipital lobe. So then you'll have loss of vision of that one side. We'll talk more about strokes. Skull and meninges and other fun stuff. So in the skull, you have 3 layers of meninges, 3 layers of connective tissue. So you've got your skull, you have the orange one is the dura mater. So the space above that is the epidural space above the dura. That's a potential space, a space that doesn't technically exist without pathology. The dura mater is also depicted in this diagram over here. It's responsible for creating all the folds that either separate the cerebral hemispheres, or it separates the cerebellum from the rest of the brain, etc. So there's lots of folds that you can see in this diagram. Under the dura mater, you've got the arachnoid mater, and between that you have the subdural space. Again, a potential space. The arachnoid mater, as you can see from this diagram and these little pockets that you can see, the arachnoid mater has all of these granules. And what the granules are responsible for, it's for letting CSF, which fills the space below it, it lets CSF leak out into the bloodstream, into the dural venous sinuses. And so that's part of how CSF is recycled back into the bloodstream. So you've got your arachnoid mater, which is the green part. Under the arachnoid mater, you have the subarachnoid space. So the subarachnoid space is filled with cerebrospinal fluid, filled with CSF. It's also where the circle of Willis sits under the brain. And then you've got the pia mater, and the pia mater is essentially just stuck to the brain, so there's no space under there. All right, so those are the meninges. Then you've got your venous sinus system. So you've got veins that, like the deep cerebral veins, that actually drain brain tissue, and all of these coalesce and drain back into the dural venous sinuses. And as we talked about earlier, the CSF also gets recycled back into the dural venous sinuses. All of this drained fluid collects and goes into the internal jugular veins, and the internal jugular veins then go into the right atrium. It might be worth it to know the names of all of these, of the main sinuses. In particular, the cavernous sinus is really important. So you can see the cavernous sinus in this diagram as well as the one down here. Within the cavernous sinus, you've got lots of really important stuff, essentially. So you've got your pituitary gland, the internal carotid arteries, as well as a bunch of cranial nerves. As you can probably imagine, if something happens in your cavernous sinus that causes the cavernous sinus to either compress or become infected or something like that, it can actually affect all of these structures that sit within the cavernous sinus. The other thing is that the cavernous sinus actually also drains the central area of your face, which is why it's not good to pop pimples or anything like that, because the infections can track back through veins and affect and sit and grow in the cavernous sinus, and which can then affect your brain. So you can end up with encephalitis or meningitis if that happens. Then you have the ventricles. So in the ventricles is where your CSF sits, right? So from this diagram, the ventricles that you can see is that your two lateral ventricles, which are the two up here, the lateral ventricles join together to form your third ventricle, which sits in the middle. The third ventricle then drains down into the cerebral aqueduct and goes into your fourth ventricle. So the fourth ventricle sits anterior to your cerebellum, which will be sitting, I can see it in this diagram. This is cerebellum, there's your fourth ventricle, and then it goes down into the central canal of your spinal cord. So the purpose of your CSF is to protect the brain, and it can also take away the metabolic waste that's produced by the brain. CSF is produced by the choroid plexus, and the choroid plexus is this specialized epithelium on the inside of all of the ventricles. So the ventricles themselves produce CSF. So the way that this happens is that the choroid plexus produces CSF, dumps all the CSF into the ventricles, and then the CSF goes through the ventricles, down the central canal of the spinal cord and things like that. It can also leave the ventricular system through the foramen of Luschka, which is over here. So it goes out through the foramen of Luschka into the subarachnoid space. This is why the subarachnoid space also has CSF. So it goes through the subarachnoid space and then covers the outside of the brain. So that's how it can protect the brain from the outside. And then after it's done going through the subarachnoid space, it leaks back through the arachnoid granules into the duodenal sinuses and then gets recycled back into the circulation. That's all of the theory parts of the lecture. So the next part is pathologies. Before we move on to pathologies, does anyone have any other questions? No? Okay. Go on to pathologies. So the pathologies that we'll go through: strokes, bleeds and hemorrhages, epilepsies and seizures, but more focused on seizures, Huntington's, Parkinson's, and the 3 infections. There is a lot of information on the slides, so you can go back and read through them when you have to revise for exams. Starting with strokes, we've already talked a lot about the blood supply of the brain and what different arteries supply. But an ischemic stroke itself is an acute injury that's caused by ischemia. So something is blocking the cerebral artery and not enough oxygenated blood is getting to the area that is meant to perfuse. So this can be for a whole range of reasons. So it can be an embolic stroke. So an embolus means that there's a chunk of stuff somewhere else in the body and a bit of the chunk has broken off. So this can be if you have atrial fibrillation and you have a thrombus sitting in your atrium and a bit of it breaks off and causes a stroke. You might have infective endocarditis and you have a lump of bacteria and gross gunk stuff, and a bit of that breaks off and then that causes the stroke. So you can have that, or you can have a thrombus. So the same way that you might get a heart attack, so you have like those fatty streaks and an atherosclerotic plaque that breaks off and forms a thrombus that can cause a stroke as well. And then there's other reasons that aren't that common. The clinical features of a stroke always depend on which artery is affected, and I already talked about what happens if you block the anterior versus middle versus posterior. If you ever get a stem that's like the patient also has either Broca's or Wernicke's, remember that both Broca's area, which sits in the frontal lobe, and Wernicke's, which sits over here in the parietal temporal region, both of those are affected by middle cerebral arteries. And so if you have either of those aphasias, you're likely to have a middle cerebral artery pathology. Then you might ask, then why don't we always have both Broca's and Wernicke's all the time? They're both supplied by the same artery. True, but it's more likely that a branch of the middle cerebral artery is blocked, and a branch might just affect Broca's area or just affect Wernicke's area. The treatment is that you reperfuse ASAP, and this reperfusion can happen in multiple different ways. So you can have intravenous thrombolytic therapy. So you can have a tissue plasminogen activator like alteplase put in through your veins. You can have an intra-arterial thrombolysis, which is a similar thing, but instead of going through your veins, you go directly into the artery and try to put medication there to thrombolyze the clot. Or you can do a thrombectomy, which is like literally pulling the clot out of the artery that's being blocked. Yeah, and then we've all heard of FAST, which is the general signs and symptoms. So you have a drooping face, in particular the forehead's being spared because a stroke is an upper motor neuron lesion. Weak arms, slurred speech, and you just have to act quite fast. So that's strokes. Then you have your bleeds, your hemorrhages. And there's 3 types of bleeds because you can bleed into 3 different spaces of your meninges. So starting from your most internal bleed is your subarachnoid hemorrhages. And as we talked about earlier, in your subarachnoid space, you've got your CSF, but you also got your circle of Willis that sits in the subarachnoid space. So a subarachnoid hemorrhage can be due to trauma, but it's most often due to a burst aneurysm. And an aneurysm is a weakening and like a outpouching of an artery of the circle of Willis, as you can see here. So hypertension is a big risk factor for subarachnoid hemorrhage because of causes your aneurysms to bleed. So the blood goes into the subarachnoid space, which is like all around here. And on a non-contrast CT, you see a star sign. So anything, you can see the white pale part of this CT, show the star sign. So that's a subarachnoid hemorrhage. Because the subarachnoid space also contains CSF, the blood can track down your spine into the CSF there. So if you do a lumbar puncture, that might also show blood, which, you know, if the subarachnoid hemorrhage is too small to see in a non-contrast CT, you might notice blood on a lumbar puncture. A subdural hemorrhage is the bleeding between the dura, so under the dura but above the arachnoid mater, and this is always venous because there's bridging veins between those 2 meningeal layers. And because this is venous, the bleeding is much slower, it's low pressure, and it can actually be more chronic. Subdurals can come for a variety of different reasons. It can be from blunt head trauma. So you might hear of like shaken babies, or if you fall a lot, anything that exerts some kind of shear forces in the brain. So if you shake, this is very gruesome, but if you shake a baby and their like brain shakes, and it can tear some of the bridging veins. Or in old age, when the brain shrinks, it takes the bridging veins along with it, and it can tear some of the veins there as well. So it can be chronic, it can sometimes be asymptomatic, or it can just cause very sort of non-specific symptoms like headaches or confusion. So that's where it bleeds into. As you notice, you've got your dura mater in the way, and your dura mater creates all of those folds between parts of the brain. So a subdural hemorrhage can never cross the midline. On a CT, it looks like a banana. Yeah, that's pretty much it, and it doesn't cross the midline. An extradural hemorrhage is bleeding outside the dura, between the skull and the dura, and it's most often because of trauma. Commonly, it can happen because of injury to the middle meningeal artery, which is easily injured. The buzzword for epidural hemorrhage is that it has a lucid interval. So whoever gets hit in the head will lose consciousness, then wake up and act normal for a bit, and then lose consciousness again. So there's a lucid interval. And it on non-contrast CT, it looks like a lemon. It's also associated with the cranial nerve 3 palsy, which causes ipsilateral pupil dilation because the cranial nerve 3 sits near the brainstem, and because there's lots of pressure coming from an arterial bleed, it sort of pushes the brain down and it squashes the cranial nerve 3 on whichever side that it's starting on. So the way I've been taught to learn the CTs, so the subarachnoid bleeding is just a star, but the mnemonic is red lemon, blue banana. So the one that looks like a lemon is red because it's arterial bleeding, so epidural. But blue banana, it's banana, it's venous bleeding because it's blue, and so it's a subdural. And that's bleeding. Next up, we've got seizures. So the definition of a seizure is a transient occurrence of signs and symptoms because there's some sort of abnormal hypersynchronization of neurons. So that's the definition of a seizure, whereas the definition of an epilepsy, like the disorder epilepsy, is having either 2 unprovoked seizures more than 24 hours apart, or 1 unprovoked seizure with some sort of predisposing factor. So seizures can be either focal or generalized. So focal seizures are the ones that are affecting a specific area of the brain. And the key difference is that focal seizures, in focal seizures, the patient is generally conscious and either awake or knows that it's happening. So the symptoms of a focal seizure depend on where in the brain that it's been affected. For example, if a seizure is happening in the frontal lobe, the patient might have some behavioral changes, or if it's happening more in the motor cortex, they can have some movement changes. Or if it happens in the parietal lobe, where the primary sensory cortex is, you can have some sensory changes. As opposed to that, generalized seizures are the ones that affect the whole brain. And so the patient is generally unresponsive, unconscious. There's lots of different kinds of generalized seizures. The most important are either absent seizures and tonic-clonic seizures. So absent seizures are the ones that you see in children. They essentially just go blank for a few seconds, and they might just stare or blink. They don't convulse in absent seizures. Tonic-clonic seizures are the most common type of general seizure. There's a prodrome, so the patient might feel a little uneasy or unwell for a couple of hours before the seizure. And it's called tonic-clonic because there's alternating moments of rigidity and then violent jerking, which is why those 2 words are there. And then after a tonic-clonic seizure, there's a post-ictal phase where the patient feels generally out of it and sick, sort of stuff. So can be because, sorry, is a subarachnoid hemorrhage and a hemorrhagic stroke the same thing? Yes and no. So subarachnoid hemorrhage comes under the umbrella of hemorrhagic stroke, but in particular, it's a hemorrhagic stroke in the subarachnoid space, whereas you could call the other 2, so subdural and epidural hemorrhages, you could call them hemorrhagic strokes as well. So, getting back to the causes of seizures, it can be caused by anything. If you could have metabolic derangements, you could just have a really, really high fever, One of the most common reasons for causing a seizure is just forgetting to take your seizure medications. And the treatment is one, avoid the things that are causing your seizures. Two, you could have medications. Valproate for generalized carbamazepine for focal and ethosuximide for absence. So those are just the three that I remember. Surgical is sort of on the fence. If there's something clearly causing the seizure, such as a brain tumor, you'd want to remove the brain tumor. But otherwise, you don't usually do surgery unless there's like exceptional circumstances where corpus callosotomy might be indicated to prevent like really like heavy ongoing damage. All right. Huntington's, and we'll do Parkinson's after this. So they're the two diseases that involve the indirect and direct pathways. So Huntington's is a genetic neurodegenerative disease, and it's because there's there's repeats in what's called the Huntingtin gene, which is present in everyone, but there's heaps of repeats in the CAG section. It's an autosomal dominant condition. It has this thing called anticipation, which means that there are so many repeats that in the gametes, either in the eggs or sperms of the person with Huntington, because there's so many repeats, when meiosis is happening, the enzymes that control DNA replication, they lose track of the repeats and they just produce more repeats. And because of that, someone with Huntington's, their children will have more repeats of the CAG sequence, and so their children will get the disease earlier. What happens with Huntington's is you lose your GABA neurons. So the GABA are the ones that are inhibitory, right? So that means dopamine kind of takes over. Because there's no GABA, there's a net increase in the amount of dopamine that's available in the basal ganglia. And because there's a net increase, we sort of look at this diagram where there's increased dopamine. And when you add dopamine to the indirect and direct pathways, you end up with increased involuntary movement. So remember, this movement is caused by the dopamine. It's not initiated by the cortex. And because of that, Huntington's has all of those like the flowy dance like chorea movements that the person cannot control. So we just have a question. If the corpus callosum is cut, what extra complications would you see? I'm not sure of that. I'd imagine there'd be some complications with maybe, oh, I don't know. I would assume that the benefits of having less seizures is greater than whatever complications that you'll end up having, but that's something that I would have to look up. Right. So in Parkinson's, it's another neurodegenerative disease, but what happens is that there's actually no, or there's a depletion of the dopaminergic neurons in the basal ganglia. So technically there's no dopamine for the indirect and direct pathways. So if there's no dopamine, we sort of look at like what the normal pathways are. But then you might ask, Nali, one of the pathways does increased movement and one of the pathways does decreased movement. So if you have no dopamine, won't you just have like net no movement? For reasons beyond the scope of preclin, Parkinson's seems to affect the indirect pathway more so than the direct pathway. So the indirect pathway stuffs up more than the direct pathway does. So the indirect pathway results in decreased movement. So you end up with more decreased movement than more increased movement, if that makes sense. So what happens as a result in Parkinson's is that the patient is unable to initiate any meaningful movement because they're trying to initiate movement, but the body is like, no, we're not going to let you move at all. So what happens in Parkinson is that you have a resting tremor, the pill rolling tremor, rigidity to passive movement, bradykinesia, so you're very slow, the shuffling of the gait, and a lot of people with Parkinson's have a very mask-like face. The way that Parkinson's is treated is by drugs. They don't have dopamine, so we give them dopamine. So you give them dopamine, but you also give them carbidopa, which prevents dopamine. Levodopa is a precursor to dopamine. So carbidopa prevents the levodopa turning into dopamine outside the brain. You can also give some dopamine agonists. So, but the problem with that is you also have to give domperidone, which is a peripheral antagonist to prevent nausea and vomiting from occurring, because dopamine can act on the GIT and cause nausea and vomiting. And you can also give drugs to prevent dopamine from being metabolized as well. Lastly, we have our 3 infections. So meningitis is the most important, I reckon, out of the 3 infections. It's the infection of the meninges. If it's bacterial, it's deadly. But if it's viral, it's mostly self-limiting. The bacterial organisms are pretty buzzwordy. So for neonates, for babies, it's group B strep. So B for babies, or agalactiae reminds me of milk, like lactase, like milk for babies. And that's transmitted from the mother to the baby during birth. In children, most commonly you have Neisseria meningitis, which is also called meningococcal disease, and this is a notifiable disease. This is the one that ends up with your rash. In adults, and like in non-immunocompromised adults, you can get strep pneumoniae, which causes pneumococcal disease, same thing. And in elderly and immunocompromised, you can have some other pathogens. Listeria, treponema can happen, is the syphilis pathogen. So treponema pallidum can cause neurosyphilis. Cryptococcus neoformis is a fungal condition. It can come from bird droppings. And if you ever see in a question that they're using an India ink stain, that's always Cryptococcus neoformis. And toxoplasmosis is the one that you get from kittens. And it's detected by a GM stain. So if you see a GM stain in the stem, that's toxoplasmosis. Your symptoms are fever, neck stiffness, headache, so the classic triad. You can also get photophobia and seizures. Seizures less likely because it's not actually affecting the brain. And in babies, because their skulls aren't fully joined together, the fontanelles, the soft bits between the sutures of their skull, might bulge because the brain and the meninges are swelling. So the diagnosis is done by a lumbar puncture. If your meningitis is bacterial, the lumbar puncture will be cloudy. The opening pressure will be really, really high because the CSF just has a lot of stuff in it. And there's low glucose because the bacteria is just eating up all the glucose. And the treatment is just antibiotics if it's bacterial. Encephalitis is the inflammation of the brain itself. You can see on the CT over here that all of this white stuff is the brain producing lots of fluid and edema. It's most commonly viral, and the most common viral cause is herpes simplex virus. And this one, the viral, is fatal if it's untreated. The symptoms are similar to meningitis, but you have more focal changes because it's the actual brain that's been affected. So you might have especially the temporal lobe is the one that's most affected, and so you might have some sort of memory loss and some loss of vision because the optic pathways go through the temporal lobe. You diagnose this with a CT or an MRI, like this one here is, and with a lumbar puncture, you would do a PCR looking for this virus, and you treat it with antivirals. And the last one is a brain abscess, so it's a focal infection. So you can see one over here. It's a collection of pus surrounded by a capsule. And you usually get this kind of infection through natural pathways in the brain that allow for infection to occur. So things like ear infections, so otitis media, or sinusitis, or things like that. Because it's a mass that's in the brain, it can create something called a stroke syndrome. So it can mimic there being a stroke there because it's kind of destroying the brain tissue in that area. You diagnose it with a CT or an MRI brain, like you see here. And I'll get to the LP in a second. So you don't do a lumbar puncture because the brain is swelling, because there's an actual mass in the brain. If you do a lumbar puncture, it's kind of like if you take a balloon and then you open the balloon and all the pressure releases. The pressure goes down through the lumbar puncture and the brain starts to herniate down the foramen magnum. And if it starts to herniate, you can cause something called coning. And coning is really bad because it squashes the medulla oblongata and the patient will not be able to breathe or control their heart rate and things like that. N plus V means nausea and vomiting. And the treatment of a brain abscess is just to drain it. And that's it from me. I put a link here to the rest of the notes about spinal tracts, but that's pretty much it for me. I'm aware that we don't have time, so if you have any questions, just email me or message me.
Cool. So before we go, thanks very much, Denali. That was a ripper lecture. Actually, I've always wanted to say this, but we've got a message from our sponsor. So if you could always hang around and watch this quick video.
When you're studying to be a healthcare professional, MIPS membership is free. So if you need insurance for your elective, clinical placement, or advice for usual and unusual circumstances while practicing, we have your back. There's round-the-clock help from experienced practitioners who have been in your shoes, so you'll never go it alone.
All right. Okay. So thanks very much, everyone. Thanks, Ali. And we have another lecture coming up at 1. So go enjoy some lunch.